for diagnosis impingement in ultrasound. We're making an abduction for the arm, detecting the subacromiohumeral distance of the patient, one at rest and again in the dynamic, and we can compare both and detect the difference between, and this is again the only tool for the impingement in clinically. Another joint is acromioclavicular joint. Usually we examine the joint in a static view. Again, we lost the causes of instability of the acromioclavicular joint. During instability, we can see the gapping between the both bones, which have a size of 4 millimeter, more than 4 millimeter, it is abnormal. This is 5.8, about 6 millimeter. This is instability of the AC joint. Another case, we can detect both the side to side and up and down abnormality. Another case, a widening occurred during the dynamic study. The muscle tear, we can detect the tear easily, but again, if we don't do the dynamic study, we're going to miss the gapping, which is the part of the criteria for the taking the decision for surgery or not. This is the rest, and this is the dynamic, and again, there is a gapping. Another case, partial thickness tear. The first look is a partial thickness tear, but we're missing the diagnosis because we didn't do the dynamic. In the dynamic, actually, it is a full thickness tear. Missing the diagnosis if we use the static ultrasound only. Again, the upper one looks like partial. In the dynamic, it is a full thickness tear. Muscle hernia is one of the complaints. The patient can complain with pain after walking for some distance and some bulging, and he cannot stop walking. He has to stop walking. Examining the patient in static ultrasound, this is usual, nothing except a perforator. Again, this perforator, we see it every day. In Doppler, we see this is normal. If we don't do dynamic, we're going to miss the diagnosis. This is the deep fascia, and this is the site of the defect. Again, we don't do the dynamic. We're missing the diagnosis. If we did the dynamic, we're going to see the bulge of the muscle during the activity. Again, we can see it in the transverse view, and we can see it in longitudinal view, and again, this is the only tool to diagnose this patient. MR examination is a static, it will be normal. Static ultrasound without dynamic will be again normal. This is a longitudinal view, and the bulge can be detected easily. Tendons, the snapping of the tendon is very common. Ankle snapping, hip snapping, wrist snapping, this is common. All snapping, we did the examination in static. In MR, we're going to miss the diagnosis. Peroneal snapping, this is the fibula, and the tendons of the peroneal longus and the brevis. During dynamic, we're making the eversion and the inversion of the foot of the patient. Both tendons are in place, no movement of the tendon. Every tendon in place. But in cases of snapping, this is the peroneus longus and peroneus brevis sliding around the tendon. During this causing the snapping, and again, we will never detect it either in MR or in static ultrasound, can detect it only on dynamic ultrasound. Another snapping, which common snapping, is hip snapping. This is the muscle, the psoas muscle, and this is the tendon of the psoas during the examination. We make flexion of the hip and examining the tendon movement at the level of the head of the femur. This is the tendon moving up during the activity. Sorry. Again, we cannot detect it in static MR or in static ultrasound. The only tool is dynamic ultrasound. Tendons, the pulleys. We have 5 pulleys. We can detect all the 5 by ultrasound. We have a problem either in the pulley itself or in the tendon. And both, we can detect both and differentiate both by the dynamic ultrasound. Flexion and extension of the finger during dynamic ultra study. This is a case of post-operative case. Patient cannot move the tendon is moving. Why? Because this is the size of the pulley, A1 pulley. This is 0.2 millimeter. We can detect it, and we can detect that the cause is the tendon cannot move under this pulley. This is tendon with multiple sutures. This is post-operative. Again, this patient will not get any benefit from the physiotherapy. The physiotherapy will not make any effect with this patient. Another type of pulley abnormality, this one, a very huge pulley. This is common in big cases of diabetes. We can detect the size of the body, and trying to move the finger, we can see the movement on the left side, no significant movement detected on the tendon in the right side. We can detect, again, that is the type of the cause, because this one can be injected and healed and treated by injection. Trigger finger, we can detect it. The tendon, we're trying to make a movement of the tendon during ultrasound examination. We can see this sliding. Again, where is the problem? Is it in the tendon or in the body? Again, second body, echogenic. This is the fibrous body. The problem and the question is there any problem in the tendon itself or not? Again, during dynamic, the tendon fibers can be detected clearly. All the fibers are there. There is no filling defect within the tendon. We can detect the tendon before and after. After sliding, the tendon is totally normal. The problem is within the body. And again, this is a difference in the management of this patient. Post-traumatic, very common. We have pain input in any joint. Again, this is ligament of the talonavicular ligament, and this is swollen and edematous. This is brain. Ultrasound static will say it's brain. MR will say it's brain, but this is not the problem. This is the normal side. Always we compare with the other side of the patient. But on dynamic, we try to move the normal side. There is no significant movement in the tarsal and in the carpal joints. But in this side, we can see there is a range of movement detected. Comparing both sides, the normal and the abnormal. This is a wide range. This causes a severe pain and will not be diagnosed except by the dynamic ultrasound. Adhesion. Patient with tendon repair, but he failed to move the finger after the operation. Is it the problem in the tendon itself or in the bursa, in the body? What is? Again, the tendon is adherent to the side of the bone, not only the bone, but also the skin and the fascia, because it moves with the dynamic movement. This patient will never get benefit from physiotherapy. He needs, again, to solve this problem of adhesion. Plate and screws. This group of cases, patient, post-operative, this is the head of the screws. Another screw, we can see this. Is it the cause of the pain of the patient? We need to take a decision, remove this screw or not. Okay? Again, the solving by dynamic ultrasound. During dynamic, we can see sliding friction with the tip of the screw. This is abnormal. This is cause the pain. It must be removed. Actually, they removed the screw. You can see the edema and the swelling become less compared to the before the operation. Another screw where this is muscle. This is the biceps femoris muscle. During movement, this friction between the screw and the muscle. Again, patient complaining of pain. X-ray will say a small tip of the screw. It should normal see it in every patient. The only clue is the dynamic ultrasound. Another case, plate and screw. This plate and screw are very good, normal. But the problem is in the other side. These screws, about 4 or 5 screws, are seen within a tendon. You can detect it within this tendon. Again, we can see a halo signs, again, loosened part. This tendon starts to be teared. We cannot move the tendon because of the nails are within the tendon, but we can still see a little movement of the screw within it. Again, it needs operative to remove this. Our last case, patient with sudden loss of ability to flex the thumb. If we're looking at this is a static. Again, we can say this is the side of the tear. But again, this is wrong. This is misdiagnosis because we didn't use the dynamic. On dynamic, we can stretch the tendon. This tendon is okay. This is not the site of the injury. We can stretch the tendon is normal. This is not a site. So we're going to search for the site of the tear more proximal at the rest. This is the site of the tear. Again, it is heterogeneous and swollen. This is abnormal. This is not usual seen in the tear. So we're going to search why. Because again, the patient doesn't have any force to make this tear. 1 minute. Okay? Again, another plate and screw. But the plate and screw are normal. There is no screw here or the other side. There is not a problem. Searching and the rest, this is another tendon. This is a flexor tendon of the second finger. Again, surrounded by reaction. This is abnormal. So is the plate causing something or not? So again, the clue in the ultrasound, in dynamic ultrasound. During dynamic, we're going to see this. This is a friction with the tendon. The patient will have this tendon going to be teared, and if after the operation, he will be teared again. The problem is to remove this plate and screw. Okay? Thank you very much.
Thank you. Thank you, Professor Hatem, for the very illustrative educational presentation. Thank you. And now it's a great pleasure to present Professor Khalid Al-Affas, a pioneer in ultrasound-guided vascular intervention, and he's a very, very dear friend. My pleasure to present him. He's going to present ultrasound-guided endovenous intervention.